Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello and welcome back. This is Adam Rosen, and you're tuning in to the Total Knee Tips and Pearls podcast. So thanks for tuning in and listening. If you haven't already subscribed, please subscribe. And if you have the chance, please leave a review. It's helpful for other people like you to find this podcast. So along with the theme in this season, we're going to talk about another classification. And, I think this classification is important because, what would orthopedics be without x-rays? Can you imagine doing our job without x-rays? We look at x-rays all the time, every day. And I really think, at least in my experience, I think the digital age has been really helpful and harmful in some ways when we talk about x-rays because, before the digital stentor and being able to snap a picture and email or text it to somebody to look at, you really had to do a better job of describing what you see in an x-ray. And I'm going to plan on going through that, kind of going over like how to do a good job in x-ray conference, like how to best describe x-rays in a future episode. But, one of the people that was very instrumental, and I did a little research when I was setting up this episode about Dr. Kellgren, that he was a very keen observer, that he was very into looking at all these minor details. He studied a lot on referred pain and enthesiopathy, but he was very involved with rheumatism, was also a surgeon. And I'll put a link. There was an interesting, in one of the rheumatology journals, there was just a whole sort of like bibliography, or basically biography of him in his time from 1911 to 2002 was when he died. And it just went into all the different things that he looked at and, how much time he spent looking at all these little details that led to some of these findings. And pretty much this classification, the Kellgren-Lawrence Classification, which bears his name as one of the authors and founders. So this was first described in 1957, Radiological Assessment of Osteoarthritis in the Annals of Rheumatology. So I'll put, again, that in the show notes so you can link to that, as well as this link just to read a little biography about the man and hear kind of what he was like and what he did. So when we talk about osteoarthritis, we're looking at x-rays. So, I think it's important to have a very good understanding both in our terminology, the medical science world, but also being able to describe it in English or a foreign language to the patient based on their understanding or their level of education. It's really easy. People all know about bone on bone, but the common question that you're going to get asked if you throw up an x-ray, we look at it in 2 seconds and go, oh, you have arthritis. They're going to go, well, why? Why do you say that? What do you see? So you really have to have a way of being able to describe these things to the patient. That is important. The other thing, which we have found has happened a lot in the past few years, is the insurance companies have sort of made it this nuisance of, making sure a patient is approved for surgery has to have certain words, little key buzz phrases, so the things they look for are severe arthritis, bone-on-bone contact, osteophytes. So all of those things, when you dictate whether or not you're billing for the x-ray interpretation also, you have to make sure that you include all of these things that you see. So when someone is not looking at the picture, that they can tell from the words, and that paints a picture in their head of what you're actually looking at. So what he described, or I guess what they described in grade 0 through grade 4. So that was their grading scale of osteoarthritis. And this was based on a AP x-ray of the knee. They looked at everything, but this is really sort of based on this AP x-ray. So grade 0 was no presence of osteoarthritis. So basically normal x-ray, normal knee. Grade 1, they described as what they called doubtful narrowing, possible osteophytes, or what they described as, osteophytic lipping. And this is the one where you kind of look and it's just at first glance, it doesn't really look super normal. You couldn't say with 100% certainty that the space is narrowed. And then maybe you see like a little bump on the edge. So, that's this grade 1. Grade 2 is possible narrowing, definite osteophytes. So this is, you're starting to see a change. You can actually point these things out, or, if you print out a picture, circle it for the patient, and like, this is a bone spur, this is early osteoarthritis, this is grade 2. Grade 3 is definite narrowing, moderate osteophytes, some sclerosis, and even some deformity of the ends of the bone. You can see this in all the joints. Typically you'll see it more like in the femoral head with bad arthritis, but you can see it, in the tibial plateau and the end of the femur, like we talked about before with the Fairbank changes of flattening of the medial femoral condyle from open to meniscectomy. So if you don't remember that, go back and listen to that episode. And then grade 4 was severe osteoarthritis, large osteophytes, severe narrowing, marked sclerosis, and a definite deformity. So those are those grading changes, 0, 1, 2, 3, 4. And I think it's very good to know that because, again, as a clinician and a scientist, you should, here's the x-rays. We have AP Rosenberg Merchant lateral. These are the findings: joint space narrowing, osteophytes, sclerosis, subchondral cystic changes, blah, 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 consistent with Kellgren-Lawrence class, grade, whatever, depending on what you saw. And it just kind of puts that information down there. Now, I also, over the years, I honestly don't use this as much. Sometimes kind of depends on who I'm talking to, but the other terminology that I use, and I think it's helpful for patients, and it's sort of a spin-off of the Brandt classification around 1990, 91, I think is when that came out. And what they talk about is sort of grade 1 is their minimal early arthritis, grade 2, grade 3, grade 4, and I kind of use their sort of percentages. So when I'm talking to patients, I'll talk about this grade 1 arthritis from the Kellgren-Lawrence is more this minimal early arthritis. That's the doubtful narrowing, possible osteophytes. Grade 2 in the Kellgren-Lawrence classification were possible narrowing, but definite osteophytes. And Brandt, it talks about percentages. I'll describe to the patient, you have more than 50% of your cartilage space remaining. So there is some narrowing, but there's still a lot of space left. And then grade 3, Kellgren-Lawrence, definite narrowing. I'm looking more in that, less than 50% of the cartilage space remaining, but they're not bone on bone yet. And then kind of grade 4, discussing more bone on bone arthritis. So I kind of use that terminology also when I'm describing my x-rays. And I like that percentage base of, as opposed to the possible definite narrowing. I think the percentage base, gives just a clearer picture in our mind. Now, also the x-ray features, again, he was a very keen observer. So he had x-ray features that he looked for. And again, these are the things when people ask me, well, why do you say I have arthritis? And sometimes I'll start with, this is why I say that you have arthritis based on your x-rays, because you have these x-ray findings that we see with osteoarthritic joints. So, number 1, they talked about osteophytes, typically around the margins, but in the knee, on the tibial spines as well. Number 2, they talked about these periarticular ossicles in their article, but mainly this was more in the hand. They also looked at rheumatism in coal miners in England. That was sort of where some of these initial studies came from. Number 3, they saw narrowing of the joint with sclerosis of the subchondral bone. Number 4 were these pseudocystic changes, but these were typically in the subchondral bone also. And then number 5 was this altered shape or altered morphology, most commonly seen in severe arthritis of the femoral head with hip arthritis, but again, you can see it anywhere. And the other thing that a lot of people have talked about also, if you're not routinely getting, is this Rosenberg x-ray. So instead of just a standing AP, this is a flexed knee PA where the beam is pointed down about 10 degrees, because there are a lot of people that you will see that have pretty decent cartilage space when they're fully upright with the knee extended, but a lot of them have more wear centrally or mid portion in the femur or posteriorly on the tibia. And when they do that flex knee view, all of a sudden now they're bone on bone arthritis. And that may make a huge difference when you're trying to decide, is this patient a candidate for an arthroscopy versus a knee replacement? They have a meniscus tear, they do have catching and locking, and I'm trying to figure out how extensive their arthritis is. Sometimes that Rosenberg view showing bone arthritis kind of lets you know this person's not going to do well with an arthroscopy. So again, there's their Kellgren-Lawrence classification: grade 0, normal; 1, doubtful narrowing; 2, possible narrowing, definite osteophytes; 3, definite narrowing, moderate osteophytes with sclerosis; and 4 is severe osteoarthritis, large osteophytes, narrowing, sclerosis, and a deformity. So kind of bury that in your brain. Again, I'll list all of this in the show notes, along with the bibliography of the original article. And then I'll also put the link of that interesting sort of biography of Dr. Kellgren, So if you're really interested, you can go back and just kind of read kind of an interesting little story that just talks about him and what type of person he was back then. So again, thanks again for listening. Keep reading, keep listening, keep studying, keep doing a great job taking care of patients, and take care of yourself too. Your health is important. If you're not healthy, you can't do a good job, for you, your patients, or your family. And until next time, I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.